Good afternoon and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our Systems Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you are using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call unless you are speaking or asking questions. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows after the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman Bridges and Susan King Lanier. For closed caption options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions and MHSU IDD TBI system announcements and updates. Our focus today is substance use services and programming. There will also be time for questions after the presentation. At this time, I would like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you, Iris. Hello, everybody. Welcome. We're very excited that you're here today with us. I want to say thank you to Iris for the introductions. Thank you to our interpreters for today. And thank you to all of our special guests. Today, we have many members of my team that are here and also community partners that are here. So I'm really excited about all the people that are coming today to talk with us about one of our priority goals, which is to prevent substance misuse and overdose. That's one of our priority goals. We're going to talk about some of our programs, some of our progress, some of our metrics, and you get to meet wonderful partners in the community that we work with every day. So I just want to express my gratitude towards the team, to Sarah, Dee Dee, Anna, the whole team for getting us ready today and for working every day with our community partners. So I'm Kelly Crosby. I'm the director here of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. On the next slide, you're going to see some of the other speakers we have today. So Mary Beth Cox, from our sister division of Public Health is here. Mary Beth is going to go through some really interesting data that the Division of Public Health tracks around substance use disorder and public substance use indicators. So she's going to go through that with us. Next slide. Anna Stanley is on our state opioid treatment authority team, our SOTA team. You've probably heard that name before. She's going to present. Next slide. We have Eric Morris, Dr. Eric Morris from Morris Clinics. Hopefully many of you know Eric, and he and Anna are going to present on our MOUD and opioid treatment programs. And then later on in the presentation, some of our friends from a UNC program will be speaking as well. But before I kick things over to Mary Beth, I want to do some quick announcements and a little tee up to what we're talking about today. So next slide, please. There are a lot of things happening this month in terms of awareness. So this month is Problem Gambling Awareness Month. I want to remind folks that at any point you can go to morethanagame.nc.gov and look at all of the resources that are available there. Everything from treatment, questions and answers, support if you're a clinician and you need resources, support if you're a person struggling with problem gambling. But please, there's a hotline there. There's a website dedicated for you. We encourage you to reach out, or if you just want more information, you're a clinician, you're a concerned family member, just go ahead and go to that website. There will be activities happening this month as well, so stay tuned for more announcements about those and use the hot links here to gather more information. Next slide. This month is also Brain Injury Awareness Month. So we encourage you this month to support individuals with brain injury. We encourage you, if you don't know about our Brain Injury Advisory Council, it is an advisory council of appointed members, but it is a public meeting. We encourage you to find out more about that and to attend. Right now, the Brain Injury Advisory Council is consulting with us or advising us, on services for people with brain injury, both traumatic and acquired. And they are actually giving us some recommendations right now on our expansion of the Medicaid traumatic brain injury waiver. Next slide, please. It is also National Developmental Disability Awareness Month. And this is an opportunity for us to remind you to please come to our Inclusion Works Lunch and Learns. We have them, I think, every single month. Here's the most recent one that's happening in March, so I encourage you to attend those. Next slide. If you missed some lunch and learns, and there have been many, here are hot links for you to actually go to the Inclusion Works webpage so you can find previous lunch and learns. Next slide. I hope everyone saw that we awarded over $3 million in direct support professional recruitment and retention grants. We weren't trying necessarily to align with Developmental Disability Awareness Month, but it worked out really nicely that way. Congratulations to all those agencies. And we're very eager to see what those recruitment and retention grants do for workforce. Remember, the goal is to help recruit and maintain workers, because that workers who stay provide stability and support for individuals with developmental disabilities and their family, and that's what we're looking for. Stay tuned for another announcement about additional recruitment and retention grants. Stay tuned, that's coming. There'll be more funding coming out. Next slide. This is a reminder slide. You know that we have been working over the past year on making our communication with the public more accessible. That's everything from redoing our website to creating one-pagers that providers can use or DSSs can use, or that you can use, the LMEs can use. We've worked in partnership with consumers, families, with our state and local CFACs. For anyone who's interested in volunteering, please use the QR code if you're interested in giving us some feedback about how it's been going. We'd love to invite you to a focus group to say, are these materials helpful or not? What would you like to see different? And how would you like us to see us distribute and use those materials differently? Next slide. We just closed the RFP for our non-law enforcement transportation pilot program. Remember, non-law enforcement transportation is transportation. It's medical transportation for an individual with in mental health, or it could be substance use crisis, who needs transportation, often from an emergency room to an inpatient facility somewhere else. And we want to have opportunities for people to get that kind of transportation that is via medical transport rather than in a police car. So we are excited about the pilot program. I can't tell you how many applicants we got. I just don't know. I'm excited about this though, but this ask is not for more applications. It's actually for an advisory group. We know that to actually implement even a pilot, we need buy-in from the entire community. That's from providers, it's from consumers, it's from families, it's from hospitals, it's from law enforcement. It's from EMTs. We need buy-in from the community just to make sure that we understand each community is very unique. Our relationships, the way our system of care works in every community is very unique. And we want to make sure this non-law enforcement transportation program fits well within the community. So we are seeking members for a specific advisory group to help us with implementation of these pilots. Next slide. Also, in honor of today's presentation, we want to mention there's some pretty exciting recovery and overdose prevention conferences happening this month. In the PowerPoint that you'll get after the presentation and posted on our website, these are hot links for all of these conferences. I believe I'll be at all of them. My team will be at all of them, and we look forward to seeing you there. Next slide. So let me do a little tee up to our special guest speakers today. Next slide. I already said this in my intro, but as you recall, we published our strategic plan. And we're going to try very hard this year to show you how we are working towards implementing the different interventions in our strategic plan, how we're making progress toward our goals, how our measures are moving hopefully in the right direction, but if not, how we're changing our behavior to help our measures move in the right direction. Today, we're going to talk about priority 3, which is preventing substance misuse and overdose. For us, we want to focus on increasing primary prevention programs. I'll talk about that just very slightly today. But really today we're going to talk most specifically about opioid use. We're going to talk about opioid treatment. We'll talk a little bit about prevention, but we'll talk about access to different types of opioid treatment we have here in the state and what we're doing to expand access. That's what we've got our special guest speakers for. And what you're hearing today, you're going to hear the things that we're doing and how we are going to work this year to even increase our footprint in these programs and similar programs across the state. On the next slide, you're going to see just one of, this is all the interventions that we are working on in this space. There's a lot. We're not going to talk about all of these today. We're going to talk about some of them. We're going to talk about OBOT, which is office-based opioid treatment. We're going to talk about opioid treatment programs, OTPs. We're going to talk about mobile OTPs. You're going to see a picture of Eric's really cool mobile clinics. I got to be in one. I have a picture of it. It's really cool. And you're going to talk about some of the methods we have for trying to increase kind of the competencies and trainings using a hub and spoke model with UNC. So we're training more clinics, whether they're in the primary care space, rural health space, and we're supporting clinics. So we're trying to up the capabilities and the comfort of people prescribing medication for opioid use disorders in disparate communities. So you'll hear more about that today as well. The last slide is actually a measure slide. So hopefully all of you have gone. If you can go to the next slide, please. Hopefully everyone has gone to our strategic plan dashboard. Each of our priority areas, as a reminder, has particular measures that we are looking at. This is not the only one we are measuring in this space. Remember, this priority is to prevent substance misuse and overdose. This is just one metric, which is the number of individuals served by opioid treatment programs. And I want to commend the community. I want to commend SODA, which is our team. I want to commend our whole substance use team. I want to commend our partners at DPH and all of our communities, because our OTP programs continue to expand. We have a lot of them across the state. They continue to expand. And we're continuing to see more and more people in those life-saving programs. And with the advent of mobile clinics, we anticipate even seeing more people access these programs across the state. So this is just one of the metrics, and you're going to hear more about them today. Next slide. A couple of things I want to say before I hand things over to Mary Beth. I want to show you some of the things that we look at and that we keep in mind as we think about improving people's access to the full continuum of substance use treatment and recovery services. So this is one of the metrics that we track. So across the country, 1 in 6 adults and 1 in 13 youth perhaps have a substance misuse issue or a substance use disorder. If you look at the bottom, that shows the rates of treatment for folks who are getting services. So unfortunately, so for example, 7% of youth may have a substance use issue. We are treating in the Medicaid population about 1% of youth with a substance misuse disorder. 16% of adults may have a substance misuse disorder, and we're treating about 6%. When you throw in treatment for people who are uninsured, that number continues to go up. We don't necessarily have access to data about people who are getting treatment through their private insurance, but we do know that we probably have some room to grow. And so one of the things our team is looking at are additional spaces and ways we can make sure that we are offering substance use treatment across all of our communities, in culturally appropriate ways. And for youth, we need more opportunities for youth. So this is one of the things that we track to see, are we missing folks? And we probably are. Next slide, please. The impact of Medicaid expansion on individuals with substance use disorder. This is a really busy slide. I get that it is. But what I want you to do is look at the column that says substance use disorder. You should study the other columns too, but this is a wonderful slide that our team uses to track the number of people who used to get state-funded only services who now get services provided by Medicaid because of Medicaid expansion. If you look at that substance use disorder group, over 43% of people that were getting state-only benefits, you might call them IPRS dollars, single stream dollars, but these are people without insurance. 43% of them now have full Medicaid benefits, which means they have access to a full array of treatment for substance misuse. And that treatment can be as long as it needs to be. The recovery journey can be long for some people. It can involve multiple levels of care, needs for medications. And so we celebrate that more people now have Medicaid and therefore more access to treatment. So that's exciting for us. Next slide. We're doing a lot to work on preventing overdose. This is my final tee up before Mary Beth. One of the things we were going to talk about today, but we ran out of time, is to talk about how much naloxone we have distributed as a department. We've distributed over 114,000 doses. We have a wonderful and thriving partnership with the Eastern Band of Cherokee Indians, who also participate in opioid use disorder programs and have naloxone distribution as well. So this cites some of those statistics. We have over 40 programs where local providers are working with local jails to provide medication in jails across the state. Just so many wonderful, good things are happening across the state. And today we're actually going to highlight some of our positive, like where we're headed in the right direction on the opioid overdose and misuse space. Next slide. Talk a little bit about our prevention campaigns. We don't talk enough about our prevention campaigns, but one of our biggest prevention campaigns in the opioid use disorder space was your Lock Your Meds, Talk It Up, Lock It Up campaign. And we have great data that says just getting that out there, telling parents, telling family members to lock up your opioids has made a real difference. It has helped people realize, oh my goodness, that's how people get access to my medications for the safety of myself, my family members, for the kids down the street who may come and hang out at my house. It's really important for me to lock up my meds. It's something I maybe never thought about it before. And we know these kind of things are changing hearts and minds. Our data shows how it's changing hearts and minds and behaviors. People are now locking up their medications and it's actually saving lives. We also have things like lockbox distribution. Probably every county now has lockbox distribution where we can give people actually safes or lockboxes to keep their medications in. Next slide. We are getting very excited about our anti-stigma campaign. Adam and Charles, I see them on this call, they're on my team. They're working with Dee Dee's team, and they are working on the Unshamed North Carolina campaign. We've seen this campaign in other states like Kentucky and California, and the goal is to really help change hearts and minds of citizens here in North Carolina. There's still a lot of stigma and shame associated with raising your hand and saying, I think I'm struggling with substance use disorders. Raising your hand and saying, my child is having an issue, my friend is having an issue. We want to help people with the shame and stigma, help them understand substance misuse better, help them understand effective treatment, and help remove any barriers that people would have to getting effective treatment or getting a job or getting housing. Lots of things happen because of stigma. People with substance misuse issues don't get treatment, but sometimes they don't get the best treatment in their neighborhood or in their friendships or in their jobs as well. So we're very excited about our anti-stigma campaign that will be starting really soon. Next slide. This, I promise, is the last slide before we go to Mary Beth. This is just the highlight slide. All this work, and I want to say thank you to the community. All of this work that everyone in the community has been doing, counties have been doing with the opioid settlement dollars, our partners at DPH to work on prevention and overdose prevention, my team here at DMH DDS US, our colleagues who are going to come from Morris Clinics and UNC to speak today. Everyone, thank you. All of the wonderful work that everyone has been doing in the opioid space is really paying off. The nation's actually looking at North Carolina because we are seeing a wonderful decrease in overdose ED visits. This is for all substances. We saw a decrease in overdose deaths and a decrease in suspected overdose deaths, and these are really high numbers. Mary Beth is going to talk more about, I hope people know in the state, we have an opioid and substance use action plan. There's a hot link there. And this is such a cool plan. It's a community plan. It's not just our division, not by any stretch. It's multiple divisions across the department, but it's the community. It's the community and all of the actions we are taking collectively to help save lives in our community and help people with substance misuse disorders. That action plan has a dashboard and a really smart colleagues over at the Division of Public Health manage this dashboard and also share the data publicly. So we've invited Mary Beth today to talk about some of the data that we're seeing. So Mary Beth's going to walk you through it. And then we're going to actually talk about some of our opioid treatment programs. Our guest speakers are going to talk about some of our programs. But first, I'm going to turn things over to Mary Beth.
Thanks so much, Director Crosby. I really appreciate the intro and the opportunity to be here with you all today. I am going to share my screen. Give me just a moment to get this up. All right. Hoping everybody is seeing my web browser with the dashboard now. I'm just going to keep going and somebody stop me if you can't see it. So I'm Mary Beth Cox. I'm an epidemiologist with the Division of Public Health and work to help manage our state's overdose dashboard and a couple other resources. And so if you're familiar and you've seen this in the past, maybe you're familiar with our monthly reports or our dashboard page, and you've just been to that in the past, it looks a lot different now. We just in December launched a new version of our data page, and I'm going to do like really high level, just a quick overview of the new page, some highlights of what's different, and just want people to know that it's there, it's a resource, and that our team is also a resource. So if you are needing, like having a data request, see something on this page that doesn't make sense to you, see something that you can't find on the page and you're really needing for the work that you do, you can always reach out to our team and we're happy to do custom data requests. We offer Epi office hours where you can schedule like a 30-minute session with one of our epidemiologists to talk through your data needs, and we can try and figure out how to best meet those. So please do reach out if you ever have any data questions. But hopefully this dashboard and the monthly reports are a resource that will be able to answer some of your questions before you have to kind of do that extra level of reaching out. If you are familiar with our monthly reports, those used to be on a different website from the dashboard. And what we've done with this new launch is just try to combine everything into one location. So it's just easier to navigate. And I wanted to highlight here, you're looking at the dashboard, couple cool like new features that we're able to do with this launch is these jump to links. So if you're really just coming to look at the monthly reports, then you can just click and it'll take you right to those. And these are really the three main sections on the dashboard: the interactive overdose data, which was kind of like our traditional dashboard, and then the monthly reports, and then a section for other resources. And so I'm just going to quickly walk us through those sections. And when you first land on the page, you're going to see always statewide overdose death and emergency department visits. And these are those same metrics that Director Crosby was just presenting. And I want to really highlight that these two measures are going to be updated on mostly a monthly basis. And so you may come to this page and see what we call provisional data, or words like an estimate or projected number. We are doing our best to try and get data out as quickly as we can. And death data are always going to be a little bit slower to finalize than emergency department visits. So you'll see this ED visit graph is through 2024. And then the death data graph is only through 2023. And we just got the final 2023 data. So this is a little bit, we just updated it last week, a little bit more up to date. And we were projecting or estimating a slight decrease from 22 to 23. We ended up seeing more like a plateau. The numbers kind of held steady. I would still say this is very encouraging because we'd had a 40% increase and then a 22% increase. So to just hold steady is encouraging. And I'll also show, as I kind of move down this page, I'll highlight where you can find even more up-to-date information, because I know here we are in March of 2025 and I'm talking about what happened in 2023. So I do want to highlight that there are more up-to-date data available. So as we scroll down this page, the first kind of big section you'll get to is the monthly overdose data reports. We always post these online, but if you want to get a little email reminder that they've gone live, then you can email us at substanceUseData@dhhs.nc.gov. We can get you added to that listserv. But they're here on the website. This opens up to a Google Drive with 4 different folders. I'm not going to go through each one of these today, but just wanted to highlight that there are 2 different reports that focus on emergency department visits. So for all drug overdose, and then for the subset that are opioid involved. And then there are 2 death reports. And so this is fentanyl positive deaths. These are deaths that haven't yet been confirmed as an overdose, but postmortem toxicology has tested positive for fentanyl. It's kind of a proxy measure for fentanyl involved overdose. And then the suspected overdose report is the only one I really want to click on today. I just want to highlight that this is a measure that's only available at the state level, but it's really our most timely way to kind of get a sense of what is going on right now. So this is the report that went out in January, and it was looking back at December of 2024. So it's very timely. This again, like think of those words: provisional, suspected, estimated. This is not the confirmed number. These are deaths that there's kind of a reason to suspect that these might have been overdoses, but they're still under investigation. But the total number of suspected and the kind of the trends overall at a state level really closely mirror what we end up seeing down the road with the confirmed data. And so looking at 2024, the suspected deaths, we saw a 27% decrease. So that's what Director Crosby was mentioning on her slide with suspected overdose death. It just gives us a much better sense of kind of like what's happening in real time. And that 27% decrease was also seen in the emergency department data from 23 to 24. So again, some really encouraging trends coming from our state data. I will point out, though, that even the suspected number with that large decrease, it's still slightly higher than what we were seeing in kind of pre-COVID years back in 2019. We're still at numbers higher than that. So lots of work still to be done. The last thing I'll say about the monthly reports is that when you go into all the other folders, you'll see the state report here and then the county reports. So we do like a county version of those emergency department reports and the fentanyl positive. We cannot do a county report for every single county. If your county has lower numbers, then there are some suppression guidelines that we have to follow to try to protect people's privacy. But if you reach out to us and ask for a custom data request, there may be some things that we could do to try to get you this information just in a different way than kind of posting a report online for anyone to access. So just because you don't see your county listed here, make sure you reach out. We could still provide those data. And then just very quickly moving down I'm back on the dashboard page here. There's the interactive overdose data. Again, this is kind of that traditional dashboard. We've got rates, counts, and then a county map for a number of different measures. So this drop down will let you pick from the death data, ED visits that I've been talking about, but some other measures as well that might be of interest. And all of these are available at the state and county level. So you could select your county here. Everything will update. If you're not a person who likes to look at graphs, if this is overwhelming to you, then we've put some text up here as well that kind of walks you through. Here's what the rate was. Here's how many people or visits that was. And then comparing it to all of the rates seen in North Carolina. So that's all of time, all counties. Are you highest, lowest, in the middle? Kind of where do you fall with this measure? And then what's the trend? Is it increasing or decreasing for the county, the state that you've selected? And then the last section I wanted to showcase was just down at the bottom, wanted folks to be aware that this is kind of like the catch-all section on the dashboard. So we do post a data download file. If you're somebody who likes to look at the numbers yourself, create your own visuals, you can download all of the data that are featured in that interactive section. The slide set here, we also put together a slide set with state level overdose data. And that's something that you can download and use in your own presentations. With the final 2023 death data available now, we're working to get this updated in the next couple weeks. So look out for a new version of that slide set. And then finally, any other resource that we put together, we'll post here. We've done some work in the past with the Office of the Chief Medical Examiner to look at trends in counterfeit pills. And then we just last week released this new 2-pager on people experiencing homelessness, and have been working to link shelter records with death data and had some findings there. So encourage you to check that resource out as well. And then the last little thing people sometimes miss, this little accordion will open up. And if you are somebody who likes to get in the weeds and wants to know, like, what's the case definition? What exactly is included here? you can check out the technical notes document, and that'll kind of give you that really in-depth overview of things. Again, we're always available if you have any questions about what's here. It's a new resource, so let us know if it's working or not working. We really do want to hear from folks and very much appreciate the opportunity to be with you and share today. I am going to pass things over, I think now to Anna and Eric, and they're going to talk about OTPs and OBOTs and mobile units. Thanks, everyone.
Thank you so much, Mary Beth. So I'm Anna Stanley. I'm going to speak to the treatment options that are available for opioid use disorder. Next slide, please. So the gold standard of care for opioid use disorder is MOUD, or medications for opioid use disorder. These medications are approved by the FDA and are clinically tailored to meet each patient's individual needs. Research shows that a combination of medication and counseling or behavioral therapies are the most successful way to ensure sustained recovery. Next slide. There are a number of benefits of MOUD, including improved survival rates, prevention or reduction in overdoses, increased retention in treatment, increased employment, better birth outcomes for pregnant women who have opioid use disorders, decreased criminal activity, and decreased risk for contracting HIV or Hep C. Next slide, please. The medications are important to treat the physiological aspects of addiction, and they are safe for long-term use, ranging from months to a lifetime. Unless the patient and medical provider agree that medication is no longer needed, it's not recommended that a patient stop taking their life-saving medication. Next slide, please. The opioid withdrawal timeline is the main reason why stopping opioids cold turkey is not very successful. You can see that the acute withdrawal symptoms are worse than the worst stomach flu that you can imagine, and the only thing that can stop it is continued opioid use. Once the physical symptoms start to dissipate, the post-acute withdrawal symptoms start to set in, and here's where we see more persistent psychological and emotional symptoms that can last for weeks or months after stopping opioid use. Next slide, please. There are 3 types of medications that work in different ways to normalize the brain chemistry, block the euphoric effects of opioids, relieve cravings, and restore normal body functions. I'm going to review them very quickly here, but you'll have access to the information in the slides. Next slide, please. Methadone is a full agonist, which fully binds to the same receptor site in the brain as heroin or other opiates, and it produces the same effect as them, but with a much longer half-life and a slower onset of action, so that when it's taken as prescribed, it doesn't produce euphoria or sedation. An adequate dose will suppress withdrawal and cravings for 24 to 36 hours and provide a blocking effect if other opiates are taken. Next slide, please. Buprenorphine is a partial agonist, which means that it produces some, but not all of the same effects as other opiates. It has a greater affinity for the opioid receptor site in the brain, so it will actively push off other opiates that are present in the system, which can lead to withdrawal. A great benefit of buprenorphine is that it has a ceiling effect, so larger doses are ineffective, making overdose when that's the only drug in the system uncommon. Next slide, please. Naltrexone is an antagonist which tightly binds to the opioid receptor site in the brain and displaces any of the opiates that are on that receptor site, so it precipitates withdrawal. But unlike methadone or buprenorphine, it doesn't produce the same type of relief from opioid withdrawal symptoms, but it can be effective if it's used in controlled settings. It does tend to be less effective in outpatient settings just due to the low patient compliance rate. Next slide. So where can we find treatment options for opioid use disorder? We have a couple of levels of care that we're going to discuss. Next slide, please. The first is office-based opioid treatment, which can really be any medical setting. So starting about 2 years ago, what used to be known as the data waiver is no longer required by the DEA for prescribers to treat patients with buprenorphine or opioid use disorder. However, office-based prescribers are still unable to prescribe methadone for the treatment of opioid use disorder. Next slide, please. So instead, our opioid treatment programs, or OTPs, they are federally and state licensed facilities where all of the FDA-approved medications can be provided, along with comprehensive services provided by a multidisciplinary treatment team. Next slide, please. Some examples of the comprehensive services offered in addition to medication are counseling, case management, linkage to resources, STI testing and referrals, naloxone distribution, specialized services for pregnant people, coordination of care between medical providers, and in some cases, integrated psychiatric and primary medical care. Next slide, please. So our OTPs are the recommended level of care for patients who have not been successful in the OBOT setting or may need methadone as opposed to buprenorphine, which we are finding more and more to be the case with the infiltration of fentanyl in the drug supply. They're also the best level of care for patients who might need to switch between medications. The multidisciplinary treatment team allows for greater access to on-site counseling, case management, and peer support services, and Medicaid and state block grant funding can provide coverage. And most of our OTPs do offer open access with same-day on-site medication availability. Next slide, please. You can find one of our 90 OTPs across the state by visiting our North Carolina Central Registry map. The link will be put in the chat. And next slide, please. We are fortunate to have so many OTPs in our state, and our patient census has increased by over 20% in the past 5 years. In the past year, our OTPs have served just under 32,000 unique patients, and 58% of those patients receive funding through Medicaid or state block grant funds. Next slide, please. An exciting opportunity in North Carolina is our ability to extend the reach of the brick and mortar OTP through mobile units and medication units. So just like it sounds, a mobile unit is a motor vehicle from which the OTP services can be physically brought to a predetermined location like a jail or residential facility. And a medication unit is a stationary unit that is established as part of an OTP that can serve another location, like a rural area. Next slide, please. Dr. Eric Morse is an OTP provider in North Carolina that is the first to operate both of those extensions. And so I'm going to turn it over to him to speak about what these units mean for the future of OTP service delivery in North Carolina.
Thank you, Anna. That was awesome. You did a great job of covering a lot of information in a short span of time. So yeah, I'm really excited about the increasing the access to care for folks with opioid use disorder through the use of medication units and mobile units. So I had the first medication unit in 2021. I knew that we had about 40 or so patients that were driving from Asheboro to Siler City on a regular basis. And some of them were dropping out of treatment because of the transportation barrier. And so 40 patients, quite honestly, isn't enough to sustain a full-fledged OTP with all the costs that are involved. So I asked permission to be a pilot project and open the first medication unit in North Carolina's history. And I got permission to do it, which was awesome. And currently we only have 77 patients, but it really didn't grow to the point where it would have been sustainable as a full-fledged OTP. But as a medication unit, all of our patients have the option to dose either in Asheboro at the Morse Clinic Asheboro or Chatham Recovery in Siler City. So if you're going west, you can dose in the Asheboro Clinic. If you're going east, you can dose in the Siler City location. There's really nothing that you can't do in a medication unit. Those regulations have changed federally, so we can do intakes in the medication unit. We can do counseling in the medication unit. So everything that you can do in the home clinic, you can also do at the medication unit, which is also true of our mobile unit. So we constructed that about a year ago, a little excited, maybe a little too excited to get the mobile van running, because we had to wait for the regs to actually happen. But it was good marketing anyway. But we have been able to get far along in the process. In fact, we're driving the mobile van tomorrow up to Dix Hill to DHSR for it to be inspected by DHSR tomorrow morning. And we anticipate providing services on St. Patrick's Day. So we're going to wear green and the red from our clinics, and it'll look a little bit like Christmas come early for us. But we're really excited. And again, there's nothing on the mobile van that we can't do from the home unit. So we can have our doctor on board. There's a doctor's office. We can do counseling. There's a counseling office. There's a restroom where we can do observed urines, and there's a dosing unit so that we can provide either methadone, buprenorphine, or naltrexone. And I think with some of the other changes in terms of being able to use telemedicine to do admissions from an OTP, we can do that in jails. We've been doing that on a grant with the Nash County Jail. We're partnering with Freedom House to provide that in a rehab. We've already with a chain of custody, and we can provide methadone to our patients in a long-term living situation like Pathways to Hope is a common partner. And we're also looking at doing methadone intakes from an emergency room. So we're getting some grant money from Vital Strategies where you would get dosed there in the emergency room, but then the next day you would come see us at one of the clinics. So some really exciting things that are just beginning to happen here that's going to make methadone in particular more accessible to patients. And because it's so challenging to get folks on buprenorphine nowadays with the precipitated withdrawal with the half-life of fentanyl is so much longer than any other opioid we've had to deal with in the past. I think methadone is going to be shown to be more effective and more helpful with the rise of fentanyl use disorder. So I'm a couple minutes over at this point. I'm going to hand it over to Kelly. I think it's going to be talking about Narcan distribution, I think. Or we're talking about STAR.
Thanks, Eric. I was going to, but we ran out of time. So we will cover that at another time. And we are about 5 minutes behind, so totally my fault for being Gabby. So I want to thank Anna and I want to thank Eric. I thank you guys for being here today. And I want to kind of remind folks about that Unshamed North Carolina anti-stigma slide that I mentioned before. And whoever, Jay, if you're running the slides, could you go back a slide so I could introduce UNC STAR? But I just want to, there are people, I know it. Keep going backwards, 2 more backwards, right there. There are people I know that are on this presentation saying, well, why are you talking so much about medications? Why are you talking about MOUD? Why are you talking about MAT? Why aren't you talking about abstinence services? I think it's really important for people to know that part of our plan is to increase access to MOUD, period, hard stop. That means more OTP clinics. It means more mobile units. It means more office-based opioid treatment. It means using programs like the mobile units. It means using NC STAR to train more practices so people have more access to medication. The goal is choice and access. People have their own recovery journeys. There's zero doubt about it. You have your own, all right? But we know that medication is an evidence-based model of care that saves lives. So everyone should have the choice to have medications in their recovery journey. That's not me saying it's the only way. It is me saying it is an evidence-based way, and we need to proliferate access to MOUD across the state. So the next partner that I want to introduce is our awesome team through the UNC Addiction Medicine Program. They do a lot of cool things. That slide that just keeps leaving the screen for some reason talks about our longstanding partnership with the team at UNC. They're going to talk about some of the work that they do in partnership with other institutions and with community partners. So not only are they providing care, they are also training new professionals, which is very exciting. They're training new professionals that know how to support people with substance misuse. And they are training more clinics and practices to be able to provide with confidence medications for opioid use disorder. So again, the goal is to increase access and choice for everyone across the state. So I'm turning this over. Gabriella or Joseph or Claire, all of you are here. So I'll just let you guys take it away. And thank you all for being here.
Yeah, thank you. And good afternoon, everyone. So my name is Joseph Williams, and I am the director of the UNC Addiction Medicine Program. And my primary responsibilities within the UNC Addiction Medicine Program include serving as the fellowship training director for our Addiction Medicine Fellowship Program, serving as the primary attending physician for UNC Medical Center's inpatient addiction consult service, and also supervising residents and fellows in the UNC Substance Treatment and Recovery Clinic. A critical component of the UNC Addiction Medicine Program is the NC STAR Network, and I would like to introduce the director of the NC STAR Network, Dr. Claire West.
Thanks, Dr. Williams. It's really lovely to be here with you all. And Director Crosby, I just loved so much what you just said, just advocating for choice and really reducing stigma and increasing access, because that's really our bag as well. I am an internal medicine doctor at UNC. I'm a clinician educator and really just fell in love with the practice of addiction when I joined UNC. And I was closely mentored by my colleagues in addiction psychiatry, and really I'm honored to have taken over directing this program late in 2024. And I'm here with my sort of triumvirate here who's been leading the program. I will let Dr. Castro introduce herself in a moment. She is my co-captain in now administering this program and really helping with understanding our data and making sure we're improving. So we'll go to the next slide. I'll talk a little bit more about what we do. So as we've referred to, we are the partner here with you all, trying to increase access, mainly doing that through education and in a variety of areas. And really we have evolved to become a network. We realized that hub and spoke models that have been developed in other states may not be exactly right for our state. We need to listen and take learnings from the community while we are teaching. And we find that bi-directional learning has been what has really helped to engage our community partners. Next slide, please. So Dr. Williams went over a little bit about the makeup of our program. I want to be respectful of time, and these slides will be here so folks can understand it and ask questions of us if needed. But essentially, UNC Chapel Hill provides inpatient addiction consult, a fellowship training program, and both consultative and addiction psychiatry in the outpatient setting. I will go ahead and go to the next slide, please. NC STAR Network is the state-funded arm, the DHHS-funded arm that takes that expertise and really tries to unite it across the state. So now we are a group that includes MAHEC in Asheville as our academic partners, as well as our colleagues at ECU. And we have been building for the past 6 years, really, relationships with all different types of community partners, just in alignment, trying to expand access and decrease stigma. Many of these community partners receive technical assistance and training from us. Others are in our community and in our communication umbrella, where we partner together to try to be creative and find ways to serve folks in each community. Next slide, please. So here we are, 24-25. You can see all the counties where we have some community involvement. We've been growing since this network was really built. This was the brainchild of Dr. Robin Jordan, who really recognized the need to have more resources for the community to access addiction psychiatry experts, and just championed building this, and has really made an incredible service that we're happy to carry on. And we'll go to the next slide. So in terms of what are we actually doing, we do teaching for those who need it. This is CME accredited teaching. We have a lovely, talented group of faculty that hail from across our academic centers, and we teach clinicians all of the different nuts and bolts about treatment of opioid use disorder in the office setting, primarily teaching about buprenorphine, but we do discuss methadone and naloxone as well, and naltrexone. But we also have a series really meant to try to address stigma, and that's really meant to be for anybody who wants it, anybody in a clinical office team or anyone in our community partners. It's not just for clinical providers. And we found that practices who engage with this together are more likely to actually provide the care. And so we really enjoy trying to embrace decreasing stigma in the treatment of addiction. But one of our most important services is really this at the elbow support. So once a practice engages with us, they have access to us as faculty, can reach us in real time with questions. That has been what we have found is most effective at increasing prescribers and clinical comfort in providing this care. So we're continuing to try to understand how to deliver that as seamlessly as possible. Excited to be working with some other partners and how to evaluate the impact of this. Go to the next slide. I'm going to pause and hand it off to my colleague, Dr. Castro, and let her talk a little bit more about some of the data in terms of what we have been doing. So thank you all so much, and nice to be here.
Thanks, Claire. And thank you guys so much for including us in this. You guys hear me okay? We're good? Okay, great. I'm in clinic in Siler City. So as Eric mentioned, this is a hotbed of need, and we're so grateful to be able to be part of NC STAR. I'm a family physician, and I came to North Carolina to start working in a rural area. And one of the needs that we found was exactly, we had zero treatment of care of opioid use disorder in not just this clinic, but many places. So it's been really in my heart to help build the residency program that we did, that we started here, the rural residency training program, and now to work with the addiction medicine program and training fellows to care for folks who are suffering with opioid use disorder. My role in this program is to help with the data, which I love because it really helps us think about what's out there, and we can kind of sample what we're doing, where we want to be, and connect with others. So to the end of the mid-year report, I want to share a little bit of what we've done, but I also want to say that a big outcome for us is to help build data infrastructure among our partners. Because if we don't know what we're doing, if we can't measure to some degree our impact, then we really don't know how to re-aim. So one of the things over the last 4 or 5 years that we're really working on is developing a network of clinics. And so we've expanded an additional 11 clinics this year for a total of 27 partner clinics. And we have data from about 10 of them. So I want to share this sample. This is 10 partner clinics. So FQs, health departments, primary care clinics, and the 3 academic hubs at MAHEC, UNC, and ECU. So in this network, in this subset, a total of 4,258 patients received MOUD. So you can imagine the rest of the network is an even larger contribution. When we look at the demographics, we can definitely tell that this is not necessarily the background population, but we're angling toward the areas where the death rates are the highest. And so this information is super important in letting us know who's being treated and who's not being treated. As you might notice, I apologize for the small figures, but I'll read the percentage in Medicaid. I don't have the prior figures here, but has jumped in the last year, and that has been instrumental in our patients getting care. So we can see that adherence is not about just a patient's will to do this. It absolutely has to do with the tremendous support that they get when they have health insurance, Medicaid in particular, and the tremendous support from DHHS in being able to do these programs. So let me see, next slide, please. Right, so our faculty from all 3 sites get together, and something really important that we do is we help work with partners to get from their implementation when they're thinking about prescribing MOUD all the way to the collaborative sessions when they're already prescribing, and then we work with them on further implementation, expansion, etc. Our faculty and staff provide over 150 sessions. Both they are including formal and informal, so didactics, individual coaching. This is not counting at the elbow support, because those are those quick calls. You can epic chat me, you can text me, you can message me in any way. And in that moment where you're sitting in front of a patient as a physician and this is your first time prescribing, you don't know what to do with the dose, just call and we can walk you through this. We can help you assess the patient. So all of this is really what facilitates care in the moment. And so we really want to be able to partner with anybody else who is doing this work. Another thing that's been important is we've had invited presentations and we've been able to disseminate this outside of the local area. So making those connections is important. So it's not just the numbers that we see here, but the impact. Let's see, next slide, please. Okay, just the quick summary. So 3 academic centers, 27 partner clinics, many additional community partnerships that could be with SSPs, with emergency departments, with hospitals. We're trying to connect with anybody that is taking care of people with OUD so we can think about how to expand the network. One of our recent partners is actually the Farm Worker Health Program, who again, we have such an overlap, amazing people doing amazing work, and we just want to help them expand in terms of what they can provide, and they can help us expand into the network, into the areas where we're not reaching yet, for a total of 4,000 or more patients receiving MOUD. Next slide, please. Okay, so our aims and deliverables really, again, to highlight, part of this is to get direct access, but a lot of it is network development. So we hope to continue, our future directions are to continue adding partners in the community, thinking about what those partnerships look like, increasing the number of patients that we're able to see, the capacity that we have at the academic center and also in the community. One of the really important things about the bidirectional relationship is that when a community health center or a health department, somebody seeing patients in the community says, I'm having trouble getting this patient to where they need to be, not only can they call us for support, but we can take a patient back at Star Clinic and say, for the moment, through telehealth, so we can reach you wherever you are, we can help you develop a management plan for this patient, have shared care, and then they transfer back to their primary care home when it's good for all. The final thing, we haven't talked a lot about our mobile unit, but we do have a mobile unit to reach Robeson County, where there are very few physicians, many patients in need. And so this was the building year. We had 98 patients seen there this year. Next slide, please. Okay, so our future directions, again, building our team. We have new team members, new expertise, more folks who are getting addiction medicine certification and board certification to be able to increase our teaching in the addiction medicine fellowship. Some great interprofessional partners, as I mentioned, now working with School of Pharmacy and thinking about how this can also inform work for other places. So we have some discussions with the NC Collaboratory, and we've just put in another proposal to think about how we can develop stigma training, because we want to be able to implement evidence-based practices as part of NC Star Network too. So partnerships with social work, with pharmacy, NC Farm Worker Health Program, and hopefully many, many more. A couple last tidbits. We have a provider forum coming up in the spring. This is going to be our first attempt at getting actually the data folks together, because again, data is important so we can all connect around what we're doing. And so that's going to be one of several initiatives that we have to expand our practice. Let's see, next slide, please. I'm not sure where we are on time. Here are our emails. Please reach out if you want to connect, if you have any thoughts, any recommendations. We're happy to do this and so grateful for the opportunity to share our work here.
Thank you so much, UNC team. And today I'm going to turn things back over to Iris in just a minute, and she's going to close us out. But just want to do a quick recap today, and something I didn't share at the top of the hour, which is for many of us, opioid use disorders and substance use disorders is really personal. 1 in 6 adults, 1 in 13 kids struggle with substance misuse. It's just part of our lives. And so one of our priorities here at the division is making sure that we have access to substance use treatment for children and adolescents. We've had a hefty focus on opioid use disorders and preventing overdose and death, but also just helping people on their recovery journeys for a long time now. You'll see in the data that we're making progress, and I'm really excited about that. I'm grateful today for Eric and the Morris clinics for all the opioid treatment programs they provide across the state, both in clinic form and now in mobile units. I appreciate the UNC team and all their many practitioner partners who are now providing medications in primary care practices and FQHCs, because we need entry pathways for everyone. People go to different places. I always tell people that I have a loved one I love dearly, huge important part of my life, received prescription opioids forever from his primary care physician. And it pretty much has destroyed his health and his life. And I always say if his physician instead had prescribed to him MOUD, medications to help with his cravings and his shakes and the withdrawal, that was a substitute for his very physical addiction and his psychological addiction, he'd have a much different life right now. So I'm very grateful to everyone who provides different types of access across all of our communities for all people that needed access in different ways to help on their recovery journey. So thank you all for joining us today. If you're interested in connecting to any of our speakers in their programs, because you want to collaborate, if you're interested in talking with us, because you're like, whoa, my community needs things, let us know. But thank you all for being here with us today. I think we hit most of the questions actually in the Q&A. And I'm going to turn things over to Iris to close this out.
If we did not get an opportunity to answer your questions during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our community engagement and training webpage. The links are included in the chat box. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar is scheduled for Monday, April 7th, 2025 from 2 to 3 p.m., and we look forward to seeing you then. This concludes our webinar for today. Thank you for attending.